Most infants are born hyperopic or farsighted. Over the first few years of life, the globe physically elongates, shifting the retina backward to intersect the focal point of incoming light. This natural, blur-driven calibration process is known as emmetropisation. In adult optometry, the primary goal is maximizing static visual acuity through optical correction. You measure the refractive error and provide the lens power necessary to neutralize it. Pediatric optometry requires a different approach, where prescriptions act as physical interventions within a rapidly closing neurophysiological developmental window. The clinician must manage two competing objectives: preserving the natural emmetropisation process while intervening early enough to prevent a permanent binocular breakdown. Two cases illustrate this balance. Ravi is a 5-year-old hyperope presenting with strabismus. Kim is a 12-year-old progressive myope dealing with binocular fatigue. These profiles highlight the clinical tension between allowing nature to take its course through undercorrection and overriding it with aggressive optical power. Effective pediatric management depends on a sequenced clinical algorithm that adapts to the patient's age and binocular status. In healthy infants, the natural history of refractive error begins with a wide distribution, typically characterized by moderate to high hyperopia. Longitudinal data shows the average spherical equivalent at 3 months is plus 2.16 diopters. By 9 months, this mean drops to plus 1.36. The rate of change then slows. By 6 years, the standard deviation compresses, stabilizing between plus 0.70 and plus 1.00 diopter. This data supports the common clinical practice of deliberate undercorrection in healthy pediatric patients. LEATS guidelines recommend that for a 4-year-old with hyperopia over plus 2.50 diopters, the clinician should undercorrect the spherical error by 1.00 to 1.50 diopters. Providing a full correction in a healthy infant eliminates retinal blur, the specific signal the eye needs to drive natural axial elongation toward emmetropia. Maintaining a mild, uncorrected hyperopic buffer is absolutely necessary to preserve the stimulus required for normal eye growth. However, the objective of preserving emmetropisation is abandoned immediately if the patient's binocularity is threatened. Ravi is 5 years old. He presents with plus 7.00 diopters and a 30 prism diopter esotropia. His eye physically turns inward. To overcome 7 diopters of hyperopia, Ravi's system exerts extreme accommodative effort, triggering an involuntary inward rotation. Undercorrecting here is a clinical error. Prescribing full cycloplegic plus power relaxes the system, returning the visual axes to parallel alignment. Once the eyes are optically aligned, the management shifts to the neurological sensory deficit caused by the turn, amblyopia. Occlusion therapy, patching the strong eye, doesn't begin until week 18, allowing the visual system to stabilize first. Once patching begins, the right eye recovers uncrowded visual acuity, improving from 619 to 67 by week 42. In cases like Ravi's, the need for motor and sensory rehabilitation overrides the physiological goal of emmetropisation. In 12-year-old Kim, the developmental window for emmetropisation has already closed. We are now managing the mechanical consequences of a mature, myopic eye. Kim's myopia is progressing, with refractive errors around minus 3.25 and axial lengths exceeding 24 millimeters. To slow axial growth, we use orthokeratology. The right eye calculation begins with the target correction, then adds a plus 0.50 Jessen factor. This overcorrection provides the required central corneal flattening, yielding a final treatment curve of 38.50 diopters. While Ortho-K addresses the optics, it does not resolve Kim's underlying binocular instability and Virgin's facility failure. Her visual system lacks the stamina to shift focus quickly between near and distance tasks. The Virgin system can no longer snap into focus efficiently. Rebuilding this motor efficiency requires a structured vision therapy program. This therapy follows 4 distinct stages, beginning with monocular flipper training, progressing to biocular alternations and binocular jump vergences, and finishing with proficiency. For older pediatric patients, optometric care focuses on active disease management and the mechanical optimization of the visual system. These interventions form a unified framework for pediatric care, structured from the bottom up. The foundation is the physiological baseline and optical correction. At this level, the clinician uses optics to either preserve emmetropisation in healthy eyes or resolve strabismus through full correction. The second tier is sensory rehabilitation. Addressing neural deficits like amblyopia is only possible once the underlying optical system is stable. Patching and other sensory therapies sit in the middle of this algorithm, entirely dependent on the accuracy of the optical foundation below them. The final tier is motor and binocular facility. Interventions like vision therapy and myopia control represent the mechanical optimization of a fully formed visual system. Clinical errors often occur when clinicians apply adult optimization goals to a developing pediatric patient, potentially halting the natural growth signals required for the eye to reach emmetropia. In pediatric care, the prescription provides the foundation for a highly sequenced developmental algorithm.